Shock is a life-threatening condition of inadequate tissue perfusion where the delivery of oxygen and the nutrient is insufficient to meet the body's metabolic demand. It is categorized as hypovolemic, cardiogenic, obstructive, and distributive. Septic shock is a major subtype of distributive shock caused by several infections. It is unique in that it can present with different clinical features that are categorized as warm or cold shock. Let us see the difference between cold shock and warm shock. Warm shock is a hyperdynamic phase. It is the early compensated phase of septic shock. Key characteristics include normal to high cardiac output, low systemic vascular resistance due to peripheral vasodilation, flushed, warm and dry skin, bounding peripheral pulses, and capillary fill is fast, pulse pressure is widened, and mental status is restlessness or confusion. It is due to cytokines which is released during the immune response, which causes widespread vasodilation and increased capillary permeability. The heart initially compensates by increasing its output. So, the characteristics of warm shock is warm, flashed extremities, bounding or full pulse, and a rapid capillary fill. And the mechanism is normal or high cardiac output and a low systemic vascular resistance. More common in adult and older child than younger child. When we came to cold shock, it is hypodynamic phase. It is a late uncompensated and a more severe phase of septic shock. In this case, cardiac output is low, systemic vascular resistance is high, as the body attempts to compensate for failing cardiac output through vasoconstriction. Skin is pale, mottled, and cool extremity. Pulse is diminished or 3D peripheral pulse. Capillary fill is delayed, pulse pressure is narrow, mental status shows deterioration. The initial compensation fails and the myocardium becomes depressed in this case. Peripheral vasoconstriction occurs in an attempt to shunt blood to vital organs, leading to poor peripheral perfusion. So cold shock is characterized by cool, mottled skin, weak peripheral pulse, slow capillary fill, and it's due to low cardiac output and high systemic vascular resistance. It's more common in infants and young children with septic shock who cannot increase heart rate and stroke volume as effectively as adults to compensate for low cardiac output. In summary, warm shock is early compensated septic shock or hyperdynamic phase, whereas cold shock is a late uncompensated with low cardiac output. When we came to treatment, distinguishing between warm and cold shock guides therapy. Warm shock focuses on reversing the vasodilation, whereas cold shock is to focus in improving cardiac output and contractility. For warm shock, use norepinephrine to increase systemic vascular resistance. For cold shock, use epinephrine for its inotropic or contractility effect. General management for both include rapid fluid resuscitation with crystalloid, early broad-spectrum antibiotics, and source control of infection. In children, special considerations include children more often present with cold shock, while adolescents and adults are more likely to present with warm shock initially. For pediatric patients, the initial vasopressor of choice for cold shock is epinephrine. Pay close attention to fluid status and the response, as children can compensate for shock for longer period before rapidly decompensating. In summary, cold and warm shock represent different hemodynamic states within the progression of septic shock. The clinical assessment of peripheral perfusion is crucial bedside tool to differentiate between the two. This distinction is important for guiding the choice of vasoactive medication and tailoring a patient's treatment strategy. Thank you for watching.